I'm Kim Kang with the League of Women Voters in Minnesota, and I'm a member from the Wayzata Plymouth League. We're very excited that you've joined us today for our program, Understanding Mental Illness and Breaking Down Barriers. Since we'll be beginning the program, we ask that everyone take this time to please turn off your cell phones if you have one. This forum is being sponsored by the West Metro Alliance, which includes the local leagues of Brooklyn Park, Osseo, Maple Grove, Crystal, New Hope, East Plymouth, Golden Valley, Minnetonka, Eden Prairie, Hopkins, St. Louis Park, South Tonka, and Wayzata, Plymouth. League of Women Voters Minnesota is an educational organization organized at the local, state, and national level to encourage citizens to participate in government. We welcome new members, both genders, men and women, and encourage you, if interested, to become a member, to be sure to sign in the registration form at the very back of the room here. While the League of Women Voters studies and takes stands on issues, we never endorse or support political parties or candidates. We do encourage our members as individuals, as we encourage each of you to become involved in your community and the political party of your choice. I'd like to remind you that League of Women Voters Minnesota is a nonpartisan political organization and that the views of the speakers are their own. The League of Women Voters Minnesota does not assume responsibility for the contents of the speaker's statements. As we go through both of our presentations today, we'd like to ask you to hold your questions until after both speakers have completed their presentation. And we'll have plenty of time then for you to ask any questions that you might have. To get things started, we'd like to welcome our first speaker. Sue Abderholden is the Executive Director of the National Alliance on Mental Illness Minnesota. We call it affectionately NAMI. NAMI Minnesota's mission is to champion justice, dignity, and respect for all people affected by mental illness. Today she'll be speaking about mental health in Minnesota, an advocacy perspective. Please have a warm welcome for Sue Abderholden.
Thank you, Kim, and thanks for inviting me here this morning. So now I just have to figure out everything. So I just want to start out talking about, a little over 50 years ago, President Kennedy actually challenged our country to go to the moon. He also challenged our society to build a community mental health system. So in his statement, he said, "We choose to go to the moon in this decade, not because they are easy, but because they are hard, because that goal will serve to organize and measure the best of our energies and skills, because that challenge is one that we are willing to accept, one we are unwilling to postpone, and one which we intend to win, and the others too." He also said that same year, "If we launch a broad new mental health program now, it will be possible within a decade or two to reduce the number of patients under custodial care. Reliance on the cold mercy of custodial isolation will be supplanted by the open warmth of community concern and capability." Well, we made it to the moon 8 years later, really an amazing accomplishment. And the Community Mental Health Act was signed into law in 1963, and we were supposed to build 1,500 community mental health centers. But frankly, 50 years later, we're still waiting. So we had the will to go to the moon. We have not had the will, actually, to build a mental health system. So just to think about it in terms of Minnesota, so we had 9,000 people in our institutions back in 1963. By 1978, we only had 1,500. So when we have, frankly, law enforcement, whatever, saying, well, the problem is we let people out of the institutions, I want to remind them how long ago that was. All right, we have had plenty of time to address that. This is not a new problem, and the folks that were released back then are probably dead now. So, we really need to kind of move on. We are at about 110 people at Anoka Regional Treatment Center now and 325 people at St. Peter. The other thing I just want to remind people is we don't want to go back to those institutions, and they were closed for a reason. I'm old enough that I went to every single institution in the 1970s when I was working on developmental disabilities. I can tell you that is not where you wanted to be. There was a lot of warehousing. They certainly weren't beautifully decorated. Really lots of horrible conditions, and frankly, they weren't homes. And like we like to say back, especially in the 70s and 80s when we were closing the institutions for people with developmental disabilities, people live in homes. They don't live in institutions. I did always like this little comic, though, that, when we closed the state hospitals, people did end up in our jails, in our homeless shelters, sometimes in private hospitals, nursing homes, and the dumpsters. So we didn't create, frankly, the community system that should have been there to support people as they closed. And that's actually how NAMI started. When the Hastings State Hospital was going to close, a group of moms, so you can always remember how to say NAMI, the NAMI mommies, got together, as women often do, around a kitchen table, and said, we're gonna get some community mental health services. And they actually passed the first bill that funded a community mental health program. This has been a problem from the beginning. So I do appreciate the fact that we have a lot of law enforcement now saying we have people with mental illnesses in our jail and they shouldn't be there, but they really have been there for quite some time. I found a NAMI flyer in the 1980s saying people who suffer from mental illness, we used to lock them up and throw away the key. Now we just drop them off on the street. Another mom, even in 1988, said, often my son was jailed when he should have been hospitalized. So again, I'm glad that they are aware of it now, but this is not a new issue at all. So why wasn't our dream realized? Well, there's a couple of key reasons. One is discrimination insurance. So, if you had a pre-existing condition, you couldn't get insurance. A lot of insurance policies didn't cover mental health treatment at all. There certainly was no mental health parity involved. We also faced discrimination on Medicaid. So Medicaid actually would not cover any institutional care for people with mental illnesses. Anything over 16 beds you could not use Medicaid for. It was called the IMD exclusion, Institute for Mental Disease. And even the TEFRA program, which is for middle-income families who have children with disabilities. If your child has a developmental disability or some other type of disability, you just need out-of-home care, and then you qualify. For a child with mental illness, they need hospital level of care. So we have far more children with developmental disabilities on the TEFRA program accessing community-based care than we do children with mental illnesses. Also, a lot of discrimination under Medicare. There's a lifetime limit on inpatient psychiatric care under Medicare. Yep, and for many years, they also had a lower percentage of payment if it was outpatient care. So first, we didn't even have insurance, public or private, really covering community-based mental health care. And if you have to rely on grant money, as many of you know, then that goes away, it comes and goes. It's not a very steady stream of income. The other problem with the IMD exclusion is that when we developed in Minnesota community-based, waivers, they were based on the fact that you were going to reduce your spending of Medicaid in the institutions. Well, we didn't have any money in Medicaid in the institutions because we weren't allowed to. So we had to kind of fit in under some other waivers. One of them is called the CADI waiver for people with disabilities, but it wasn't really set up for people with mental illnesses. So it hasn't really worked quite as well. And a lot of those programs that people with mental illness tried to get into really didn't understand how the symptoms of mental illness play out. So we could have, for example, recently with the Department of Human Services, they were changing the eligibility criteria for the personal care attendant program. And they literally said to us, well, if you have quadriplegia, you need someone to come in and literally feed you or you will starve. But if you're someone with schizophrenia and you have your symptoms, delusional thoughts or whatever, makes it difficult for you to kind of comprehend time and get groceries and all of that, they said, well, they could feed themselves if they wanted to. So just not understanding at all about how symptoms of mental illness play out. The other thing is that what we saw a lot is that people's healthcare symptoms were not addressed. We have people with schizophrenia who don't want to tell someone in the emergency room that they have schizophrenia if they're having heart pain or something like that because they're afraid that their symptoms will just be, brushed off because, by the way, this person is psychotic. Very, very different treatment on an inpatient psychiatric unit in terms of visiting hours, how people are treated. Housing, a huge issue is that if you are in an apartment building and the police come to your apartment too many times, you can actually lose your apartment. The owner can kick you out for that because of city codes. And yet they're calling 911 because they're having a mental health crisis, and we didn't at the time have a health care response to that crisis. Underemployment, the Americans with Disabilities Act is rarely used for someone with a mental illness. People kind of know if someone comes in a wheelchair or maybe they're hard of hearing or they're blind, we kind of understand the accommodations. Most employers have absolutely no idea what the accommodations are for a person with a mental illness. On the education side, kids who did end up in special education and were often in what we called EBD, emotionally or behaviorally disturbed, segregated classrooms. Kids with mental illnesses have a very, very high dropout rate, frankly, and a high suspension rate too. So we ended up really having very few community supports, no way to pay for those very services that can help people. We know housing first is an important piece. If you don't have stable housing, you can't really get better, and yet those are things that we didn't fund. Few employment programs were targeted for people with mental illness. Most of our programs are kind of, drop and walk away when those symptoms can come back, and people might need help. And then our main way into getting onto medical assistance is actually saying that you have a disability, and yet the Social Security Administration made it very, very difficult for people with mental illnesses to get on that because they couldn't figure out if in fact you were disabled or not, and maybe you were faking the symptoms. Most people had to apply 3 or 4 times before they could qualify. We also, even today, have a huge provider shortage. We have 9 regions of our state that have a mental health professional shortage, not just psychiatrists, but licensed clinical social workers, psychologists, marriage and family therapists. We have 33% fewer psychiatrists per capita than other states, so we know that's a huge problem. We even have 13 counties that don't have any psychologists, 10 counties without a clinical social worker. So that makes it very hard to actually access treatment if you don't have the workers there. And then a huge reason is stigma. And actually, the Surgeon General back in 1999 said of all the different barriers that people face to accessing treatment, stigma is one of the largest. And I just want to spend a few minutes on this because I think people don't really think about how stigma really impacts both kids and adults with mental illnesses and their families. So stigma is actually a really nice word, frankly, for discrimination. That's really what it ends up leading to. It affects our attitudes, how we treat people with mental illnesses, and usually that ends up with people being discriminated against. Patrick Corrigan wrote one of the kind of leading books, and he's done probably the most research on the impact of stigma. And he actually lives with a mental illness, and he said the stigma we face is in many ways more disabling than the illnesses themselves. So if you kind of had a picture in your mind of someone, frankly, who lived with schizophrenia, maybe severe bipolar disorder, usually the picture is someone who doesn't look like you, right? They're usually sometimes kind of older, homeless, they look disheveled. Someone you might see on the Nicollet Mall in the middle of July wearing a heavy coat, talking to themselves. It's never a positive image when people come up with it. So if it's not a positive image, why would you ever want to say that's what you have? If it's not a positive image, why would you want to tell your friends that that's what your son or your daughter has developed? You don't want anyone to think that that's what you're going to look like. And so it makes it very hard then to have an image of someone with a mental illness that you can relate to. How we talk about mental illnesses is really no different. So there's lots of slang words, right? So I'll start. If you've had enough coffee, you might join in. Crazy, nuts, psycho, loony. There's a lot of words out there, right? I mean, we could go on and on. A little bit more coffee and you could just keep going, right? But then I want to ask you, so what are the slang words we have for cancer or heart disease? Now, I'm not trying to be the word police, but we all know, and there's a lot of women who are even older than me in this room, and when we went on the job, we were called girls, right? We changed our language. Every civil rights movement has changed their language over time to try to bring dignity and respect to that group of people. And we don't do it for mental illness. We even had a jar, what we called a swear jar, in one of the inpatient psychiatric units in the Twin Cities metro area. So on the psych unit, and every time any of the workers there, whether they were a psychiatrist or a nurse or whatever, anytime they used any of those words, they had to put money in that jar. They raised a lot of money for the NAMI walk that year. So even in a place where you're supposed to be treating people, those words abound. And I would just challenge you, just for today, just count how many times you hear the word crazy. Now, you might say, well, it's really not that big of a deal. But what if it's if it's your illness? What if your illness that you have struggled with so hard and you're hearing that word constantly? It is not an easy thing to hear. Here's how we usually kind of describe or talk about people with mental illnesses, right? They're afraid, they're weak, maybe selfish, violent comes in a lot, especially with people with schizophrenia. Maybe they're incompetent, they're irresponsible. What about these words? Shouldn't we be using these words to describe people with mental illnesses? Doesn't it take an incredible amount of courage if you have schizophrenia? You're hearing those negative voices constantly, but you get up and you leave your house and maybe you go to a job or you go to a drop-in center or something like that. Determination. You live with serious depression. Do you know how much determination it takes to leave your house? Or if you have anxiety? Inspirational. Ellen Sachs is actually an attorney in California. She is amazing. She won one of the MacArthur Genius Grants, and she lives with schizophrenia. I find her incredibly inspirational. Generous. Talk to any homeless shelter. The people with mental illness who come in are the first to give up their jackets to someone that they think is colder. And nonviolent. In this one, I just want to stress, only 5% of the violent crimes committed in our country are committed by someone with a serious mental illness. Unfortunately, when they do, it's on the front page, and then people make that leap that people with mental illnesses are violent. The media portrayal doesn't help us at all. So we know that, especially on TV, people with mental illnesses are found to be 10 times more violent than other TV characters and 10 to 20 times more violent than in reality. And we get a lot of our, attitudes, frankly, are formed by media and by television. And they found that people who watch a lot of TV avoid people with schizophrenia. They don't want them living next door to them. They don't want to work with them because, again, on TV, they're portrayed as being violent. Luckily, these drinks were taken off the market, but the schizo one was brought to me by a dad whose son has schizophrenia, who really likes energy drinks. And he found it in the cooler at the 7-Eleven or Super America. And he brought it to me and he said, my son has struggled so hard with this illness. I don't know what he'd say if he found this in there. How crushed he would be. This is an actual donut shop in California. You can see the bipolar one has chopped nuts on it and coconut flakes. And Pete Early, who is an author and a writer, I think for the Washington Post, he wrote to them whose son has schizophrenia, and he said, really our heart breaks for our son. It has been such a tough journey, and you're sitting there making fun of him. How could you do that? And they wrote back and they said, well, you can go to any other donut shop in the country. Here's a Minnesota-based company. My God, what have I done? He went to the wrong jewelry store for his engagement ring. When we wrote to them, we said, why are you promoting suicide? And they said, we're not promoting suicide. And stigma impacts things big and littles. I can tell you that a lot of mental health and healthcare professionals don't include families. And I just want to say HIPAA doesn't require you to be stupid. When people complain about, people with mental illnesses keep returning back to the hospital a few weeks after they've been discharged, you want to say, well, you discharged them without anyone in the room, and you're surprised. We don't involve families at all, and yet no one gets through a serious illness by themselves. When I first came to NAMI 13 years ago, I asked people with a serious mental illness, when you were hospitalized, did you ever receive a get well card? And they all said no. You're in there an average of 8 days, not just one day. And no one's reaching out to say, I'm thinking about you. No one's reaching out to you to say, I think you're going to get better. We call it the no hot dish illness. When your loved one is hospitalized with a serious mental illness, I can tell you no one's bringing you meals, no one's bringing cookies over, no one's saying, oh, let me watch your kids while you go visit your husband. None of that happens at all. I've had many NAMI mommies come to me and say, I went to my priest, my rabbi, my minister to say that my son has schizophrenia, and they've said, don't worry, we won't put them on the prayer list, no one will know. And yet this is when they need the prayers the most. People with a serious mental illness, especially if they've been committed, that's a public record. They can find that record online. You can go to the Supreme Court website and find out who's been committed, and then they don't get rented to or hired. Again, no accommodations at work. The visiting hours are usually horrible. Like many people at NAMI, I'm a family member, and when my daughter was hospitalized, by the time she was registered into the hospital, it was 2 a.m. on a Friday. I said, I'll be back later that day with some clean clothes for her, and they said, no, I'm sorry, you can't visit her until Saturday. That's when visiting hours are, between 4 and 5 on Saturday afternoon. She was 13. I said, no, I'm coming back, and I did. And then I worked to change that policy. But, if she had appendicitis, I could have slept on the floor. And so, that make it very hard for family members to actually be involved. And then how many of you have ever seen a Caring Bridge site for someone with a serious mental illness? I've seen 2. And one of them, the guy, his wife finally convinced him to do it, and she put it up, and his faith community wanted to do something to help him. And so she put on there, the deck of cards there are so worn out you can barely play them. And they didn't have his favorite pop. And so every day someone came with a new deck of cards and a can of pop, and he was thrilled, and he felt supported, and it actually really helped him in his recovery. So the problem with all of this, lack of treatment, lack of supports, lack of community caring is that we have really poor outcomes for both kids and adults. So people live with their symptoms an average of 10 years before seeking help. Even a young person having their first psychotic episode lives with those symptoms an average of 74 weeks. We don't even have barely 60% actually get treatment. And the average lifespan is the same as if you were born in Bangladesh. So people are dying 20 years earlier, not because of suicide, but because of their other health care conditions that are not being attended to. We know that a huge percentage of people who are homeless have a mental illness. People with a mental illness have the lowest employment rate of all the disabilities. Around 60% of the people in our jails have a symptom of mental illness. Doesn't mean they've been diagnosed, but they have a symptom. And 25% of our prison population have actually been diagnosed. Again, kids have higher suspension rates. Behavior is the #1 reason for out-of-home placements. Kids with who are categorized in special ed as EBD obviously don't have a very good graduation rate. And then 70% of the kids in the juvenile justice system, not just in Minnesota, but across the country, have one or more mental health diagnoses. Even if we look at kids who are in the correction system in special ed, a large percent of them are categorized as having EBD. And then even kids who are homeless, we know 73% are taking medication for their mental health. Suicide is the leading cause of violent death in our state. Close to 700 people die every year in Minnesota, and that rate has been going up. The other thing that kind of bothers me about that whole issue, and my background is in public health, is that with public health issues, we kind of like to have data right away. I can tell you today how many people have Ebola in Africa. I cannot tell you today how many people died by suicide in Hennepin County last month, the month before that, or even all of last year. Our data is 2 years old. Makes it hard to really attack an issue. We know people have difficulty having friends, and what we hear a lot from young people who have a mental illness, especially ones who've been, more recently diagnosed, is that, they're watching their friends' lives go forward. They're getting jobs, they're finishing college, they're getting married, they have a car, they have their own apartment, and they're sitting there in their parents' basement without anything to do. So where are we now? So I'm all about a hopeful message. I want to say that we've actually made progress. There's a lot of people that would say we have a broken system of care. I wouldn't actually say that. I would actually say that we actually have a foundation. We just have never built our mental health system. You can't break something that doesn't exist. And so we really made some huge progress back in 2006 and 2007. It was really a banner year for mental health. It was the largest increase of new money in our state's history for our mental health system. And it was proposed by a Republican governor and passed by a Democratic legislature. I like to say that we have been supported and screwed by both parties, so no one is, everyone can claim credit and blame, frankly. But we started a lot of community-based services back then. ARM services, adult rehab mental health services, where people can go into the home. Assertive community treatment teams, which are like a hospital without walls. Children's therapeutic services and supports, which I know Mary will talk about. Mental health crisis teams, mobile crisis teams. School-linked mental health grants, which I think are the best things since sliced bread, where we go to where the children are. We don't expect the schools to do it. We give the grants to mental health providers to do that. Respite care, giving families a break to recharge their batteries. So all of these different things. We got more money that year for Bridges Housing, which is kind of like Section 8 for people with mental illness, and supportive housing. We started to fund actually an evidence-based practice for employment for people with a mental illness. So we really kind of moved forward, and even getting finally mental health parity, which was really a huge step. Our 2013 session was also a huge, we made huge gains that year. It was really in response to the Sandy Hook shootings, and while we didn't want to necessarily connect violence and mental illness, it was also an opportunity to get more money for children, and we did. And I think, and Mary and I sat there on New Year's Eve day with a couple of other people around a kitchen table and came up with 12 bills with 27 provisions, and 17 of them passed. And so it was really a banner year, again, for making progress for kids. Some other things that were added that year as well was, again, mental health first aid training for youth, which I know we've been doing. NAMI's got the contract, and we've been doing that around the state to really increase people's literacy on mental health. Rate increases for mental health providers so that, you know, they do good work. They need to be able to hire people. And mobile crisis service, I want to focus a little bit on that because we are looking again, well, maybe I'll wait till this, we're working on it this session, so I'll wait till then. In that year, we were able to increase the school-linked mental health grants by 100%. So we were able to really get into more schools. Started a text message crisis line. You know, kids don't call, right? They text. And so here we are sitting there with, you know, suicide hotlines that are never used by young people. So putting this in made a huge thing. Mental health education in the schools. Our young people need to know, what are the signs and symptoms? How do I help myself? How do I help my friends? We also had a bill that looked at workforce shortages, but for the first time, instead of the mental health community kind of sitting around talking to ourselves, we brought in higher education. So MNSCU was actually appointed to lead the charge, and so we had a great 2 years worth of work and holding a summit and doing surveys and hearings around the state, and the report came out in February, and really looking at, so what are the things that we can do to improve that? We also created a new thing that hasn't quite gone into effect yet, but called family peer specialists. So hiring moms and dads who have a child with a mental illness or had a child with a mental illness to work in our mental health system. They can help break down some of those barriers and break down the stigma as well. We made some changes to medical assistance so that providers could bill for more things, which again just, you know, kind of helps our system. And I'm just going to skip that. I'm just going to go to the 2015 session because that's much more fun. So we decided it was going to be another year for mental health. And I do want to say it feels like about every 7 years or so we start, you know, really focusing again. The mental health community has really come together. We have something called the Mental Health Legislative Network, close to 40 organizations. We put together what we thought needed to be done. We gave it to the Department of Human Services. They adopted most of what we wanted, and then there were a few things that they didn't, so we're still working on those. And what we're really telling legislators, especially, frankly, on the House side, since it's a Republican majority, is that we're actually building on what we started in 2007 under Governor Pawlenty. We want to finish up what we started, and we want to make sure that services are fully funded. When I testified at the Capitol on the governor's bill, I actually wore a yellow hard hat, construction hat, to really say, you know, we are building on our foundation. We absolutely know what works. We're not sitting out there going, oh, you can just throw more money at the mental health system and nothing's going to work. We know what works. We know ACT teams work. We know mental health crisis teams work, so we need to really fund them. So there's a couple of different categories: prevention and early intervention, treatment, recovery, workforce, and then other. So for prevention and early intervention, one thing is to expand on a program that's been operating for a couple of years where we're bringing mental health professionals to kind of consult with child care providers, Head Start, you know, those kinds of providers when they have children whose symptoms or their behaviors just are not really within the norms. And then they can get that help to know what to do for that child to really help them move forward. Most people have heard about the Adverse Childhood Experiences studies. The ACEs study is what they call them. So there would be some money in there for the Children's Mental Health Collaboratives in the future to really see on a community-wide basis what can we do. I do want to caution people about that study. You know, when we start looking at all the different ways that we have, you know, that kids experience these adverse things in their lives, there's a lot that we can't prevent. We can't prevent tornadoes. We can't prevent, you know, even some kids from witnessing violence in their neighborhoods. I mean, there's a lot that we can't do. And the point of the study was not to check off how many adverse experiences that child has and then point to the parents. The point of the study was to say, some kids experience a lot of adverse experiences and they're resilient and they can go on and be successful adults, and some children cannot. So what can we do to really help those children be more resilient, not so much pointing at parents. Mental health crisis services. we don't yet have 24/7 services across the state. When police and sheriffs say, again, we have too many people in our jail, well, the problem is that if you have a mental health crisis, you call 911 and the police come out. Well, you want to say, duh, of course, and then it's up to the police officer based on his or her training to either bring someone to an emergency room or bring someone to the jail. So what we want to have is a healthcare response to a healthcare issue. And so we have these mental health crisis teams. Unfortunately, we have some areas where they really aren't available at all. We have some areas where they're available before 6 o'clock at night. Well, I don't know about you, but my crises always happen after 6 o'clock in anything, right? So that's not very helpful. And then we have some teams that really are very functioning, except that they need more, like Hennepin County. They have a great team, but they need more staff in order to meet the demand. So we would really pump a lot of money into this system. The other thing we would do is create one phone number. Right now there are 44. Depending on where you live in the state, which makes it very hard to publicize. And we also want to make sure that we have standards so everyone really knows what will happen when those teams come out. And then we also want to create more crisis beds. What we hear from adults with mental illnesses is they're far more likely to actually go to a crisis home early on in their symptoms returning versus an emergency room. They're not afraid they're going to be committed. It's much more home-like and so much easier to get into. And so we want more of those developed. I know a lot of people say, well, people have to wait to get a bed, and so we should just build more beds. So my kind of statement back to you would be, so we want to build the most expensive part of our system. It's a front door and a back door issue. We want to make sure that people don't get into the hospital when they don't need to, and we want to make sure that once they get in, that we get them into the right services afterwards so that they can, continue on their recovery. But just building more beds, we will fill them, but we won't necessarily solve the problem. Another thing is first episode, which is something that I really care deeply about. If you go to your doctor and your doctor tells you have cancer, they don't say come back when you hit stage 4. And that's exactly what we do in the mental health system. We say wait until you've been committed numerous times, wait until you've been hospitalized numerous times, then we'll provide intensive services. We need to turn this up on its head. And when that young person in 20, 21, 23 finds out that they are having a psychotic, symptoms, we need to throw everything that we have at them. Therapy, education, meeting, frequently with their psychiatrist or their prescriber, helping them get back to school or work so the trajectory of their life doesn't change much. On the treatment side, we want to build kind of a different residential side for kids, so step down from a hospital a little higher than our residential services. Behavioral health homes, we're really wrapping ourselves around that young person or that older person with the serious mental illnesses. Really looking at the rates that we pay our mental health providers. We often ask them to do 12 things and we pay for 6. And then they're not viable and then they close. We need to work at that. And then when we look at some of our services, we haven't quite figured out how to pay for the housing piece, particularly for crisis bed and IRTs. And then schooling, we'd like to continue to increase that, which is not in the governor's budget, and youth shelter linked as well. More funding for respite care. Housing with supports is another important piece. There's a new thing called the Excellence in Mental Health Act on the federal level. We don't actually have a federal definition for a mental health center, so this would be an opportunity for us to get increased Medicaid match, try it out in Minnesota, be one of the kind of leading states about what that should mean. Our ACT teams, those kind of teams, Hospitals Without Walls, we need to really expand them. And we want to do something called forensic ACT teams. So for people who are coming out of prison who have schizophrenia or bipolar disorder, to really help them do better in the community. Clubhouses are kind of like drop-in centers on steroids. Some of you might know Vale Place is a clubhouse. We'd like that to be a Medicaid service. Other states have done that. That would bring in a much better stream of funding for those programs. And the other thing is that under Medicaid, you get to use what's called non-emergency medical transportation to bring you to any Medicaid service. So then we could use that to actually bring people to a drop-in center like a clubhouse so that people are getting out of their houses and doing something and getting better. There's no way if you're sitting in your apartment smoking cigarettes, drinking coffee, and watching daytime TV that you'll get better, and we need to make sure that people either get to work or get to a drop-in center. The personal care assistant program that I talked about, where we don't understand the symptoms and how it can impact someone, they changed the criteria so that in order to be eligible, you have to require constant supervision. people with mental illnesses don't need constant supervision. So a lot of them are going to be tossed off this program, which is not a good thing. And then the governor included money for the positive behavior intervention and supports programs in our schools, which really helps a lot of children, frankly, have better behaviors. On our workforce, the governor includes one new slot for psychiatry. We'd like to see 4. There's several bills that would expand the loan forgiveness program to people with mental illnesses, professionals. I typed that in wrong last night. Professionals with mental illnesses, and then trying to use more of our peer specialists or adults who live with mental illnesses in our programs. Suicide prevention is a huge one. There hasn't been a bill to increase our funding for suicide prevention since I've been at NAMI. So that's been a long time. And we would also bring a task force together to figure out how can we get faster data on this issue. We want to be able to do what's called postvention. So you know what prevention is, and postvention is where you come in after a suicide's taken place, particularly when it involves young people. You don't want there to be contagion, and so for other young people then to take their lives because they've seen what's happened. More money for Text for Life. We want to do something that's called protected transport. There's nothing more embarrassing than being handcuffed and put in the back of a police car because you're having a mental health crisis. We could do a thing called protected transport. We did pass it last year, but without money, where it's an unmarked car. You have 2 drivers who are actually trained in de-escalation and on mental illnesses. There's no lights, and people can be transported that way, and Medicaid funding pay for it. We have Yellow Medicine County does it, Beltrami County does it. They realize that this is a better way to go than using your police or sheriff, and you can use Medicaid funds. And then there was a mentally ill and dangerous task force, and one of the things they wanted to make sure is that people who are committed as mentally ill and dangerous to St. Peter, that they actually get their case reviewed every 3 years. Right now, there's no date. So if they don't ask, they don't get reviewed. And we think that that's not really a very good thing. So that's kind of what we see is going to happen for the legislative session. This is my favorite quote. We make the road by walking. And really what that means for me is that if we're really interested in improving the mental health system, then we all have to take those steps to make that happen. We really are trying to build a movement on mental health so that anyone who's impacted really knows how to raise their voice. They know what issues they need to talk about. They know what bills are going through. They learn how to talk to their legislators about this issue and to share their stories so that we reduce the stigma. But it takes all of us taking those steps to do that. And as Margaret Mead said, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. And I'm just going to end with this. When we talk about building a movement, we really need people to act for themselves. What we saw during the even the 2013 legislative session is we had a lot of adults and family members who had adults come down and say, it was awful when my kid was young. We couldn't get services. The schools didn't understand my kid. And I don't want that to happen for anyone else. So I'm going to talk up on this bill. It's not going to benefit me individually, but it's going to benefit the next generation. And that's what we really need to be about. Thank you.
Thank you, Sue. Let me see if we can get to the next presentation from here, how this is going to work. Let's see.
Did you find it?
I did not. Technical assistance.
Sorry.
Here we go. Great. Thank you. Our second speaker is Mary Regan. Mary is the Executive Director of the Minnesota Council of Child Caring Agencies, a statewide association of providers of treatment services for children and adolescents. She has more than 15 years of experience working with children and adolescents in residential treatment programs and is recognized as a tireless advocate for children's mental health issues. Please welcome Mary Regan.
Thank you, Kim, and thanks to all of you. I always feel like I need to take a deep breath after listening to Sue, and I spend a lot of time with Sue at the Capitol, and she has as much energy, 18 hours at the Capitol, as she had for that 40 minutes here, and I don't know how she does it because I can't do it. So I was asked to talk about children's mental health. So I'm going to do my best to do that. As Kim said, I do have prior experience working with children in mental health settings, specifically residential treatment centers in Minnesota and Illinois. But for the last 20 years, I have been the director of the Minnesota Council of Child Caring Agencies. And we're a provider association, so our members provide a whole range of services for children with mental illnesses, for homeless youth, for children in the juvenile justice system, and for children coming through the child welfare system. So what is mental health? Ideally, it's reaching developmental and emotional milestones, having healthy social skills, and knowing how to cope when something goes wrong. Everybody, children, adults, all of us are on a continuum of mental health and physical health. We all have various little things that work better than others, various ways that we function better than others. But it's really about the brain functioning normally. So mental health is a brain process. And it's an interaction between the actual brain and what we develop in terms of the neurons and the connections that we make through experience, and the connection with between experience and then expectation and reality. So developmental milestones, walking and talking. Emotional milestones have to do with learning how to self-regulate. At 2, when you say no, you might get tantrum in response. At 5, if you say no and you get a tantrum in response, that might indicate some difficulties in regulating emotion. Oops, I didn't make the change. What's happening? Oh, sorry. So mentally healthy children have a positive quality of life and can function well at home, in school, and in their communities. What is mental illness in children? Really, it's a serious change in their ability to learn, behave, or handle their emotions. And it's not all that uncommon. 1 in 5 children, or 20%, experience a mental illness. And it is not a reflection of poor parenting, as Sue mentioned. I want to talk a little bit about a couple of more common mental illnesses in children, and one is depression. There are 2 types of depression. One is major depression, and that's a very intensive episode that lasts for more than 2 weeks. It can recur throughout a person's lifetime. And then there's another form of depression called dysthymia, which is a milder form of depression that typically is just underlying, and it can last for a long time. Some of the symptoms for children when they're dealing with depression, obviously looking depressed, but also being irritable. Often children who are dealing with depression look angry. They look really irritated. They're unhappy, but their unhappiness is expressed in a more active way than adults. There may be a change in grades, in their ability to have relationships with other kids, getting into trouble at school. There may be a change in their eating habits. You may see mood swings. They may talk about or just act as if they're worthless. May be very restless, have frequent episodes of sadness or crying, withdraw from friends and activities, have a loss of energy. And all that really does lead to low self-esteem, and sometimes in very serious situations, thoughts of death or suicide. Another fairly common set of mental illness disorders for children are related to anxiety. And there are a whole list of them, including things like post-traumatic stress disorder, but I'm going to talk briefly about some of the ones that are more common. One is just generalized anxiety disorder. It's really excessive worry about a lot of things. They're often very perfectionistic kids, and they need constant approval or reassurance. Obsessive compulsive disorder, intrusive thoughts that tell the kid they need to repeat this practice over and over to lower their anxiety. Hand washing is common. Sometimes checking to make sure doors are locked, things like that. Social anxiety disorder, kids who have a really intense fear of performing, of being called on in class, of people noticing them. And then separation anxiety disorder. That is not a disorder if you're between the ages of 18 months and 3 years. That's normal. That's supposed to be there. If you don't see any separation anxiety, then you worry about attachment, right? But after that time, it can be a problem. Now, all of these symptoms are things that you will see in normal children, right? In healthy children. It's not about the actual symptom. It's about how debilitating is it. How frequent is it? How constant is it? Many kids are shy. Many kids struggle with new experiences. But with support, if they can move into it and try kindergarten or try high school and do fine, they're not going to be diagnosed as having an anxiety disorder. But if they can't be encouraged and supported, and the symptoms last for an extended period of time, that's when you need to look to see what else might be going on. So developmental stages are really, as I was saying, things that happen at specific points in time in a child's development. And it's a little different for each child based on their own genetics, their own situation. But many children exhibit some of these symptoms at those transitional times. And as I said, that's not critical. What's important is if they're able to move on. So when should somebody seek help? Well, the sort of standard response and what you'll read in different places is if something is persistent and intensive for at least 2 weeks, then you might want to get it checked out. But again, you're going to know your child or your grandchild or your niece or your nephew, and you'll be able to tell, if you're paying attention, that this is either something that's should be watched or could be encouraged or supported, or it's time to get some help. Early intervention, as Sue was talking about, is critical. Since mental illness is about how the brain works, when patterns of thinking or patterns of feeling continue, your brain actually makes a pathway to keep that going. So the longer you stay in that pattern, the more fixed that way of thinking, that way of feeling is. So if kids get intervention early, get treatment about how to change those pathways, they can move on and move out of that. So who can help? There are, I've got my pages mixed up here, so I'll stop reading those. Usually the first stop is the primary care physician. Is this normal? Is my child doing what you think is normal? Is there anything I need to be worried about here? And they will often be able to do a screening and an assessment to rule out any physical problems, any other things that might be going on that would be affecting the child. And then they're able to make a referral if needed. And the referral might be to a wide range of mental health professionals. Lots of primary care physicians have relationships with mental health professionals in the community that they use. And as Sue mentioned, there's a range of those in Minnesota. Licensed independent clinical social workers, psychologists, marriage and family therapists, psychiatric nurses, psychiatrists are all considered mental health professionals. Licensed professional clinical counselors. It can be confusing to track all of those different folks, but those are all the folks who are considered mental health professionals in Minnesota. And what they would do is a more comprehensive assessment to try to tease out what's happening. And often it's not just one thing. Sometimes kids with depression develop anxiety or vice versa. So a mental health professional can really help sort through what's going on and how intensive the problem might be. And a really important source is other people, friends, family, parent support groups. NAMI has amazing parent support groups all around the state that can be really helpful to help people understand, is this what's happening here and how do I cope with this. And there is an incredible service array in Minnesota, as Sue mentioned. It's not sufficient in many places in the state, but it is available somewhere. In the metro area, we have much more access than we have in other parts of the state. I wanted to talk a little bit about early childhood mental health services. Believe it or not, what we're learning about brain development is that even infants and toddlers can have mental health problems. And often those problems are exhibited through a failure to grow, failure to thrive it's called, so they may actually not grow at a normal rate. Infants and toddlers can be happy, but they can also be very sad and very withdrawn. They're especially vulnerable to parent well-being because infants think of themselves as one with the mom or the primary caretaker. So if mom is struggling, the infant, in a sense, is struggling as well. So it's really important for moms to get a lot of support. We know about postpartum depression. We know how frequent it can be that new moms feel depressed. We all know, and I think we all do send cards, we all do bring hot dishes when moms have babies. But it's even more important for a mom who has a history of depression to get a lot of support at those times. The incidence of postpartum depression is 5 to 25% for all women, but it's as high as 40 to 60% for poor moms. So in addition, and these early childhood mental health services are really pretty interesting. They're relatively new, and there aren't a lot of mental health providers who've been certified to do this work, but the ones that have are doing some amazing work in daycare centers. And being able to go in and work with the child and work with the professionals in the daycare center to create the right environment for that particular child to thrive. And they also have small groups. They have day treatment, actually, for 3-year-olds, which is pretty amazing. But it's proving to be very effective. So the rest of the continuum, outpatient services are usually clinic-based. They're often offered in the community mental health centers that Sue talked about. Professionals in private practice will provide outpatient services. And basically, you're going to an office, you're getting a session, you're getting psychotherapy. It may be your child getting it individually. It may be a family session. School-linked mental health services, Sue mentioned that. Professionals are going into the school, providing psychotherapy groups for kids, skill-building groups for kids, and they're right there. Mom doesn't have to come, take them to a session, have the child miss school, have mom miss work, dad. It's right there. It also helps normalize that response and helps normalize the experience of getting help when you're having problems. In-home services, the CTSS services that Sue talked about, were designed to be able to be used wherever the child and family are and wherever they need the services. So the professional can go into the home if that's what's best for that child and family. The professional can go into the school. The professional can go into the daycare center. It's a really amazing continuum that's not offered in many other states in the country. Then there's day treatment, which is a package of those services that's offered often in conjunction with education. So there might be 3 hours of education and 3 hours of treatment services that are offered for children, and they work together as a group throughout the day. Crisis services, Sue talked about mobile crisis teams. Mental health residential treatment, we have, I believe it's 10 residential treatment centers around the state of Minnesota that are available for children who need more intensive services than can be provided in the community. And they are programs like St. Joseph's Home for Children in Minneapolis, St. Cloud Children's Home, Northwood Center in Duluth. There are a number of programs, many of whom originated in orphanages. They were started by religious communities or women to help children who had been orphaned or whose families couldn't afford to take care of them. And over the years, they evolved into a different type of service altogether, and now almost all of them have what's called a mental health certification. Length of stay is much shorter, but the services are much more intensive. And they're designed to really provide intensive treatment for children who need that level of care. And then, as Sue mentioned, inpatient psychiatric services. So questions to ask if you need help for your family. How is the person that you've been referred to licensed, or how is the person that you're interviewing licensed? One of the things that we know about effectiveness of treatment is that the relationship is one of the most powerful pieces. It's almost more powerful than the particular approach that the professional uses, because it is about that connection and that sense of trust. So it's important that you and your child feel that connection or are able to develop it with someone. So you want to know what's their experience. Do they have specialties? Just because your primary care physician referred you doesn't mean that that person has particular experience with the issue that you think your daughter or son is dealing with. What are their outcomes? What do they find in their practice? What's the expected length of treatment? Are we talking about 6 sessions over 2 months, or are you suggesting this is 6 months a day treatment? And how will the family be involved? How can the family be involved? Who to contact with questions or concerns, and what's the cost? Insurance plans cover different professionals in different ways. They have networks, so it's important to find out if your professional is included in that network in order to get the coverage that you need. I just like that picture. So resources. NAMI, obviously, NAMI helps. There are tons of resources on Sue's website. The Minnesota Association for Children's Mental Health is another wonderful resource. They do lots of trainings around the state during the year, and often targeted at parents. The Minnesota Association for Community Mental Health Programs, the community mental health centers around the state, that's their association. And then the final one is our association, and we try to have resources and information available on that site as well. As Sue suggested, there's lots to do. And I think if there was one thing that in addition to the stigma focus that Sue mentioned, it would be to make sure that your legislator knows that you believe children's mental health funding and services are important and that they deserve their support. There's going to be a big battle this year about any money being spent on these services. And the only way, as Sue indicated, the only way that changes is if they hear from constituents that it matters. So thank you.
Thank you, Mary and Sue. I'm going to have both of you obviously come to the podium now to answer any questions from the audience. And I'd like to ask if you please go to the podium to the back, because we have a microphone there and we are taping the program, so it just makes it much easier, first of all, for everyone to hear, and secondly, for any person watching the videotaping to hear the questions. So I'm going to hand it over to Sue and Mary, and I'm going to go back to the podium as well. Thank you.
Yes.
Hi, I'm Debbie Blake from the St. Louis Park League. And it's just a comment and question. My husband had a number of mental illnesses, bipolar being the major one. And he strangled me and then he hung himself. And I have to say, the St. Louis Park Police, they were handing me pamphlets as they're getting my story and telling me of all these resources for me. And they came and visited me another time to make sure everything was okay. I don't know if it's like that in every town, but I was really impressed with the way they helped me.
Well, I'm really glad to hear that they did a great job. It's not the same everywhere. There is a kind of what we call the gold standard training for police called CIT, Crisis Intervention Team Training. It's 40 hours a week. It came out of Memphis after someone there who lived with a serious mental illness was shot and killed. And the Sam Cochran, who was the chief there, said we have to do something different. And so they developed the CIT training. We do have many police who have been trained in Minnesota. It tends to be more kind of the larger cities and some of the suburban cities. Minneapolis has trained a lot of their officers. There's usually at least one trained on every shift in every precinct. I know St. Louis Park has trained theirs, but again, it does vary, and we have, for every good story, we can give you a bad story when an officer came in and was not trained. You know, police officers are trained to come into a situation involving anything as big, right? They got to come in big and strong, you know, when they come into a situation. But when you come in for a mental health crisis, that's like adding gasoline to the fire. And so they have to kind of relearn how you come in with empathy, how you come in quietly, how you sit beside someone and not straight across for them. So they have to learn totally different skills. But they can. And when they do learn those skills, then we have much better outcomes.
Hi, Aggie Lighthizer, also from St. Louis Park League. And thank you both for your presentations today. I think you gave us a lot to think about. One of the challenges I would think, though, is diagnosis of mental illness. There's not a blood test that you take and off you go. Could you talk a little bit about the challenges you see in doing that, and how does that make your work more difficult?
Well, there used to be a group at the Capitol that made our life more difficult until they moved to Florida. I hope they're very warm down there. But that's what they would say. And Scientologists, and there are some groups like that saying, except there's actually, there is research being done on a blood test for schizophrenia. And with the technology in terms of PET scans and MRIs, they think that we will be able to use those as diagnostic tools in the future. You know, if you think about it, we had EKG machines came out in what, like 1890 or something like that, or the early 1900s, and yet how long did it take for us to start using that as a diagnostic tool? So I think we're kind of in the same boat. One thing that we always tell families of kids and adults is to really write things down, because there's some symptoms that go across several different mental illnesses, and so you really need to know the full spectrum of that, and that will really help. And all of us can't, you know, when you're in the midst of these things, you can't remember everything. So we're like, write it down. What did you see when? You know, what kinds of things are you seeing to really help the clinician diagnose their child? And I don't know, Mary, you want to add anything? Because you've done this work.
Yeah, no, I think that's really true, and I think what we recognize is that because of the status of what we know and don't know, that all we can really do is put symptoms together under a category to try to understand the picture, but it doesn't tell you the whole story. And I think in particular for children, because they're developing and changing, all of those symptoms change as well. So it's much trickier, but it's getting better, and hopefully will get better.
Sue and Mary, could you share a little information about kind of the current, I guess, status of mental health services in schools, and particularly the challenges kind of associated with that?
Well, I think the school-linked mental health program, which is Sue has mentioned, and is really funded by giving providers grants that they can then use to pay for services that they provide in schools. They have to have a relationship and a contract with a particular school. And then those grants will pay for the kinds of things that can't be paid for or aren't paid for with insurance coverage. So for example, working with teachers, attending IEP meetings, spending time helping the classroom with information about mental illness, for example. If they're actually providing mental health services, then those can be billed. The challenge is that it isn't statewide, it isn't in all schools, and there's still, I think we're still kind of sorting through what the firewalls should be between education and mental health. What is it that the team, which includes teachers and includes mental health service providers, need? What is the information that needs to be shared, and what is the information that doesn't need to be shared in the best interest of the child? Some of those things are still being, I think, worked on.
And I think I just add that I really do like the way that we did it in Minnesota, because it is not the schools actually providing the treatment. We don't think that's their role. And then those would become school records and not HIPAA compliant. And so we think it's really good to at least start with that firewall moving forward. And a lot of the school support personnel, some of the discussions in the schools have been about, well, but we have a school social worker, we have a school psychologist, but often they're not licensed as a clinician. And so they have a very important role to play. But you have some kids, they just need a little help from a teacher every now and then, in terms of having appropriate behaviors in the classroom. And then you have another group that maybe need a little bit more, and that's where the school social worker and even the school psychologists and the counselors can come in. And then you have kids that really need treatment. And what we found in the first 5 years of this program is that half of the kids who received treatment had never received treatment before, and half of those children had a serious emotional disturbance. So they weren't doing well in school. And as some of the schools really implemented this, they found that suspension rates went down, reading scores went up, and kids were actually doing better. And so, and actually in Minneapolis schools, we were able to make sure that we were getting rid of some of the healthcare disparities, and they were really seeing a culturally diverse, rich kind of pool of kids in their program. So we think that was a really good thing too.
Hi, Debbie Price from Wayzata, Plymouth. How can we follow the bills that you support that are coming up for a vote in the legislature?
So through NAMI Minnesota, through our website, you can sign up for a legislative update. It comes out every weekend. Whenever I get back and finish it, it'll be sent out. And it'll give you more than you ever wanted to know, so you can kind of skip around, but you'll at least know what's coming up this next week, because we actually have several bills coming up this week, including our Day on the Hill, which is on Thursday. Anyway, you'll get all the information there. We send out action alerts, things like that. So if you just go to namihelps.org and click on, I think it says advocate, click on there and put in your email and you'll get it.
Okay, one last question, and this is probably my favorite question. If you could give us maybe 1 to 2 things that you think we could do in our community to increase awareness and advocacy around mental illness, what would it be?
Just 1 or 2?
You want to go first?
Well, in a way, I think what Sue's already talked about is really important. Just looking at your own language, and I had to be sensitized to that whole notion of, of the way we talk, and the more sensitized I became to it, the more I heard it, the more I realized that people just use the word crazy all the time, and so changing our own language. But I also think to the extent that we can share our own experiences and our own awareness and offer support to other people we know who may be struggling with mental illnesses, that starts to change our community, and I think that's where the difference is really important.
Yeah, I think the only thing I would add, NAMI is also part of the Make It Okay campaign, so that really people start talking about it. And the research that's been done on reducing stigma is that every time someone shares their own story, you take a brick off that wall. And so we think sharing the stories is really important. There's the big things like calling your legislators, but there is the little things, when you know that someone has a loved one who's hospitalized because of depression or schizophrenia, bring them a meal. Send a card. You hear someone's hospitalized, send that card. You will be amazed. They will remember it for a very, very long time. And so I think just as communities, we need to respond. And there's there's also making sure that we have the services available in our communities. Every community needs to be accepting of whether we need a children's program or an adult program, because it's everyone. It's, our communities are filled with people with mental illnesses. We need those services and supports in our communities. And, helping if NIMBY comes up, not my backyard, really helping to overcome that is also, I think, really, really important.
Thank you, everyone. You will have an agenda and actually contact info for Sue and Mary's on the back of there. So if you have any questions later on, there's also a link to the presentations if you didn't get a copy today that is on the agenda. So with that, this is the end of our program today. We want to thank our speakers for coming today. As Thomas Jefferson once said, informed citizenry is at the heart of a dynamic democracy. And we hope this program today has provided more insight into understanding mental illness and breaking down barriers. If you'd like further information on the League of Women Voters Minnesota, once again, please sure to sign the registration sheet in the back, or you can visit our website at www.lwvmn.org. Thank you to the City of St. Louis Park for the use of their city council chambers, and to Reg Dunlap for taping this program for us today. This recorded program will be available within a week and can be found at Park TV St. Louis Park, and that's at www.youtube.com/slpcable. Thank you, everyone, and have a nice sunny afternoon.